Good morning, everyone. Today's seminar is on surgery for rectal cancers. I'll briefly be describing the anatomy, how did the history of surgery for rectal cancers evolve, concept of TMEs, and explain the indication techniques and overall complications for the surgery for rectal cancers, mainly the anterior resection, low anterior resection, ultra-low anterior resection, intersphincteric resection, APR, and ELAPE.
Two things, Nisha, I think you can be a bit slow. We have ample amount of time, and Dr. Chetan, you can keep on asking wherever you feel. It is not necessary that we need to ask at the end. We can keep on asking the things to her as well as to the residents. Open-ended.
Bilkul, sir.
Carry on, Nisha.
Okay, sir. Coming to the anatomy of the rectum, rectum per se means a straight tube, which was seen in the quadrupeds. However, in humans, it follows the sacral hollow. The anatomists and surgeons differ in defining the landmarks of the rectum. For the anatomist, it begins at the rectosigmoid junction, which is essentially at the level of S3 vertebrae, and ends at the anorectal sling, which is at the level of levator ani, and continues as anal canal. For the surgeon, it is at the level of sacral promontory, where the tinea cola is placed out to form the outer longitudinal layer of the rectum. Approximate length of the rectum is somewhere between 12 to 15 centimeters. The rectum is divided into upper 1/3, middle 1/3, and the distal 1/3. The upper 1/3 has been covered on its anterior as well as the lateral sides is peritonalized, while the middle rectum is covered only on its anterior surface by the peritoneum, while the distal rectum is essentially an extraperitoneum. Coming to the pelvic fascia covering the rectum, in males, anteriorly, it has been called as a denovenous fascia, which separates the rectum from the prostate and seminal vesicles, while in females, it is the rectovaginal fascia. Posteriorly, it has been named as the Walde's fascia, which I'll be describing in the later slides. For all the practical purposes, the Japanese and the Western divide the rectum differently. For the Japanese, they divide it into upper rectum and lower rectum. Anything which is less up to 8 centimeter from the anal verge is the lower rectum, and above that is the upper rectum for Japanese. While the Westerns as well as we Indians divided into upper 1/3, middle 1/3, and lower 1/3. The lower 1/3 is up to 7 centimeters from the anal verge. The mid rectum is between 7 to 11 centimeters, and the upper rectum is between 11 to 15 centimeters. Well, depending for the lower rectal tumors, they are further divided into low rectal tumors and very low rectal tumors. The low rectal tumor is up to 6 centimeters from the anal verge, and very low rectal tumors are where the tumors are lying within 1 centimeter from the dentate line.
Nisha, can I interrupt? Nisha,
sorry, sir.
Your previous slide, please. Yeah. So, do you think there is any significance why Japanese call it as upper and lower, and why we call it as upper, middle, and lower? Do we have any significance of that?
Not really. So this is just based on the anatomical definitions that they had given. They go in for a very aggressive surgery for the low rectal tumors in the Japanese, while Westerns try and
anything in relation to neoadjuvant, anything in relation to primary surgery?
When it comes to the low mid-rectal and low rectal tumors, if it is locally advanced, they try and go in for a neoadjuvant chemoradiotherapy. Whereas in Japanese, they go in for an upfront surgery with lateral pelvic lymph node dissection, LLND, which I'll be describing in the later slides.
No, Nisha sir is giving you a very definite hint. With regards to neoadjuvant therapy, what is the difference between approach for upper rectal tumors and lower rectal tumors?
For the low rectal tumors, the neoadjuvant therapy is both in form of chemo as well as radiotherapy. Not so in this thing, Japanese.
No. Basically, there is a concept of now total elimination of radiotherapy. So for upper rectal tumors, you can do without doing a radiotherapy and do just a chemotherapy. Nisha, go ahead.
Coming to the middle rectal valve, it forms a very important landmark as it defines the lowest point of the anterior peritoneal reflection. All the tumors above it are essentially the intraperitoneal rectal tumors, and the tumors below it are the extraperitoneal rectal tumors. Coming to how the history of surgeries for rectal cancers evolved, the first radical surgery was done by Miles in 1908, who did the abdominoperineal resection, which followed the concept of the Hallstadian principle. And this was proposed for treatment. This remained a treatment of choice for upper, middle, as well as the lower rectal tumors for a long years. And these patients ended up with permanent colostomy. As in time evolved, from Miles, Claude Dixon proposed the anterior resection in 1948. Then Parks in 1976 performed the first coloanal anastomosis. Not only did the technique for the rectal cancer surgery evolve, but also the technology. With the introduction of the surgical staplers in 1977, did add on to the evolution of rectal cancer surgery. And the landmark lies in 1982 when Professor Bill Heald performed his first total mesorectal excision. And now we have progressed to Hojo and Moreva's nerve-sparing TME and various trials which are comparing the open and the laparoscopic surgery. So essentially, we divide the surgery for rectal cancers into the sphincter-saving restorative procedures and the radical procedures with permanent stomas. Among the sphincter-saving restorative surgery, we have anterior resection, low anterior resection, ultra-low anterior resection, intersphincteric resection, and local excision in form of total transanal excision, transanal endoscopic surgery, transanal minimally invasive surgery, which has been performed for a very selective low rectal tumors, and radical procedures in form of APR with abdominoperineal resection and the extralevator abdominoperineal excision have been described. Today's seminar mainly lies among these anterior resection, LAR, ultra-low anterior resection, intersphincteric resection, APR, and ELAPE.
Nisha.
Yes, sir.
At this juncture, I would like to tell you that you missed out on another procedure which is now commonly being done, that is TME.
Yes, sir. I am describing it in the subsequent slides, sir.
Okay.
As the concept of the TME comes in and what are been the recent advances have been added up in this presentation a little while later.
Perfect. Okay, go ahead.
Yes, sir. So the aim of management in treating a patient with rectal cancer, we need to go about achieving R0 resection because that is going to bring down the loco-regional recurrence, obtain a good survival in form of disease-free survival and overall survival, maintain a good quality of life in terms of sphincter preservation, not only sphincter preservation, but to have a good functional outcomes in terms of continence and stool frequency, and to have a preservation of sexual and urinary function by preserving the pelvic autonomic nervous system. Coming to the broad overview of how the options for rectal cancer have been available. For the upper 1/3, we have anterior resection, middle 1/3 low anterior resection, and lower 1/3 rectal cancers are being, depending upon the Rouillet's classification, we have various ultra-low LAR, intersphincteric resection, APR, ELAPE, with its individual indications, which I'll be talking about in the subsequent slides. Coming to the concept of what is this distal margin for the rectal tumors, traditionally, 5 centimeter distal resection margin was considered to be adequate. If this had to be followed, most of the patients ended up with abdominoperineal resection and a permanent colostomy for the rest of their life. So various research was done when they found that the longitudinal lymphatic flow was primarily upward in the rectum. The cancer cells did not spread distally more than 1 centimeter from the macroscopic distal end of the tumor. Thus, the concept of 2 centimeter distal margin was introduced, and they said it was safe for the oncological resection. However, for the very low rectal tumors, which I'll be talking about, even a 1 centimeter margin is considered to be adequate. Coming to the concept of...
Sorry, Nisha, the histological grade of the tumor is important. Because if it is a poorly differentiated tumor, then 1 centimeter may not be acceptable. Whereas many people now, especially after neoadjuvant treatment, if it is a well-differentiated tumor, even 1 centimeter may be good enough. So grade of the tumor is very important in deciding whether you will have adequate margin and whether you can conserve the sphincter or not.
Yes, sir. Coming to the concept of circumferential resection.
Residents who are there as participants, if you don't ask, then I'll have to ask you. Are you all ready? Okay, let me ask, who is Sager? Sager is from? Sager. Please unmute yourself. Sager. Pranoy Gupta. Nobody is ready to unmute himself. Can we have Sager? Okay, Nisha, you carry on. I'll request Avinash to unmute them one by one so that we can ask a question randomly to them. If you don't ask, then we will ask. Carry on, Nisha.
Coming to the concept of circumferential resection margin in rectal tumors, this basically refers to surgically resected surface of the rectum, which is corresponding to the non-peritonealized part of the rectum. So for the upper rectal tumors, the CRM exists mainly posteriorly, which is the non-peritonealized region. For the mid-rectal tumors, it is both posterior as well as the lateral margin. And for lower rectal tumors, which are essentially extra peritoneal, below the peritoneal reflection, it is complete circumferential margin. The circumferential resection margin of less than 1 mm was considered as positive margin. And it was said that in a patient with a positive CRM, there was 85% was associated with a very high, that is 85% of local recurrence rate. And even an adjuvant radiotherapy did not compensate for a positive CRM. That's why in Mercury trial, to define the CRM on MRI became very important, essentially for all the patients with rectal cancer tumors. It is the shortest distance between the outer edge of the tumor and the mesorectal fascia. So essentially for a T3 tumor, which is beyond the muscularis propria, this is the shortest distance that has been available between the edge of the tumor and the mesorectal fascia. For T3A, T3B, T3A, which is less than 1 mm, for T3B, which is between 1 to 5 mm, for T3C, which is between 5 to 15 mm, and T3D, which is more than 15 mm. And it was defined that those patients who had CRM greater than 2 millimeter, that is the distance between the edge of the tumor and the mesorectal fascia more than 2 mm, was considered to be a CRM negative. Those in between 1 to 2 millimeter was considered to be as threatened, and those individuals with less than 1 mm was considered to be as positive. And essentially in all the threatened CRM and negative CRM, it is advised to go in for a neoadjuvant chemoradiotherapy. Coming to the concept of total mesorectal excision, it was Professor Bill Heald in 1982 who introduced this concept and said that this should be used for all the rectal cancer surgeries. He believed that the rectum is covered with an embryological envelope. So the rectum is covered with an embryological envelope called as a mesorectum, which contains all the fibrofatty tissue containing the lymph nodes as well as the vascular vessels. Even the superior rectal artery lies underneath the mesorectal fascia. Further, this mesorectal fascia is also called as a fascia propria of the rectum, which is also called as visceral layer of the pelvic fascia. And the parietal layer of the pelvic fascia is the fascia which lies outerwise. In front of the sacrum, we have the presacral plexus, which is being covered by the presacral fascia. And in front of the presacral plexus is what the essentially the pelvic autonomic nervous system lies. And the layer which is covering this is called as a Kinugava's fascia. So essentially, the parietal layer of the pelvic fascia has two layers. The layer which is covering the sacral venous plexus, called as a presacral fascia, and the one which is being covering the pelvic nerves is the Kinugava's fascia. So when we do the TME, we are supposed to we should lie in the plane which is between the mesorectal fascia and the Kinugava's fascia. To define TME, it is sharp, precise dissection under direct vision of the mesorectal envelope. To dissect it in the avascular layer between the visceral layer of the pelvic fascia and the parietal layer of the pelvic fascia. The advantages of this TME was that it reduces, if we lie in this plane, it reduces the local recurrence to less than 5%, takes care of all the lymph nodes which is lying within the rectal fascia, helps to achieve the adequate CRM, thereby preserving the autonomic nervous preservation. And since essentially it is a bloodless, loose avascular plane, will have less blood loss, and it's a safe surgery. Coming to the components of TME, to lie in the correct plane between the VLPF and the PLPF, to do a sharp dissection rather than a blunt dissection under direct vision, gentle opening of this plane to remove the entire mesorectum without breaching it, that thereby to achieve a complete TME, and high ligation of the IMA and IMV and with adequate distal resection margin and circumferential margin. The staple line should lie horizontal and at the same level between the bowel and the mesentery. So depending upon the quality and the completeness of the mesorectum, Quirke and et al. Divided it into complete TME, nearly complete TME and incomplete TME. While in the complete TME, we have almost a cylindrical specimen coming out. We have marginal coning in near complete TME, and in complete TME, there's marked coning. This is post-resection. So the approach to TME can be in form of open surgery, can be in form of laparoscopy, which is completely laparoscopic, or a lap assisted or a hand assisted one, or it could even be hybrid with both lap and open combined together with lap mobilization and open resection. It could also be robotic, and something that has been newer concept is the transanal TME, which I'll be talking about in the subsequent slides.
Nisha, can I interrupt you here?
Yes, sir.
So what do you mean by high ligation of IMA and IMV?
Yes, sir. I'm defining right in the subsequent slides. Yes, sir. I've written it up, sir. Coming to the individual surgery, we have anterior resection. We define anterior resection as when the distal extent of resection is above the middle rectal valve, that which marks the point of peritoneal reflection, and the anastomosis is to the peritonealized rectum. It is also called as, it's also known by the name called as high anterior resection. It is indicated for rectosigmoid and the upper rectal tumors and malignant tumors, and for the benign etiology being strictures and high-grade polyps. Why did the name anterior resection come in? Because there's something also called as a posterior resection, which is done in pediatric patients, where the approach to the rectal tumors is through transsacral route or a transcoccygeal route. And here in anterior resection, since we are approaching through the anterior abdominal wall, essentially we are lying anterior to the presacrum, hence the name anterior resection. The essential steps of anterior resection is patient with mid-lithotomy position. It could be a midline laparotomy, or if we are doing it in the laparoscopy, the standard port placement. Once we go in, we rule out the metastasis, we mobilize we look for the resectability of the tumor, define the lower margin of the rectal tumor, and mobilize the left colon and the sigmoid colon in a medial to the lateral approach. We need to ligate the IMA. There are two concepts. One is a high ligation of the IMA, and the other one being the low ligation. Low ligation is we ligate the IMA after the takeoff of the left colonic artery, and the high ligation is proximal to the takeoff of the proximal to the left colonic vessel. Once we mobilize the rectum, we maintain the TME plane, and we go into the rectum, go posteriorly, then go laterally, and then anteriorly. In the males, the limit is still the denonvillous fascia, and in the females, it is the rectovaginal septum. The main two concepts that has to be maintained in the TMA is preserve the nurse and try to see that we stay away from the ureter. Once that is being done, we resect the excise the rectum, exteriorize the specimen, and we can do in an anastomosis using a CED circular stapler. And it's better always, it's better to do the leak test always to rule out if there's any misfiring of the stapler or if there's a positive leak rate. The concept of high ligation versus low ligation came in when the no-touch isolation technique was introduced, which said that we have to go in and do a very high ligation of the lymphovascular pedicle. Turnbull said that they had improved 5-year survival. However, the studies have shown that there is no much benefit with high ligation of the IMA unless and until there are large nodes which are present at the base of the IMA. And high ligation of the IMA is favored when we need to have a tension-free anastomosis, because they say that the high ligation of the IMA will give an extra 2 to 3 centimeter of length, and that will help us to obtain a tension-free anastomosis. And the supply to the rest of the colon will be maintained by the marginal artery of Drummond. However, in those patients where the marginal artery of Drummond is compromised, especially in those diabetics, in those obese individuals, and in the patients with pre-surgery atherosclerosis, high ligation of the IMA might compromise the anastomosis, because the marginal artery of Drummond will be compromised in these individuals.
So Nisha, where exactly do you ligate in highlight? Do you do high ligation of this? At which point do you ligate when you do high ligation?
So 1 centimeter from the takeoff from the aorta, sir. Proximal.
Why you have to keep 1 centimeter?
So 1 centimeter because those splanchnic nerves arise in that area, sir. So to prevent the injury to the.
So basically, you want to spare the sympathetic nerve plexus.
Yes, sir. Yes, sir. Yes,
so in your practice, you said that you could do either high or low. In your practice, what do you do?
Sir, unless and until there are no major nodes at the base of the IMA, we do the low ligation, sir. And especially if we have to get a extra bit of length, that's when we go in and then divide the IMV at the lower border of the pancreas and the IMA proximally. And if not that, we generally do a low ligation, sir.
But you would always want a tension-free anastomosis.
Yes, sir. Tension-free anastomosis, that's when we will consider this.
And where do you ligate the vein?
So at the lower border of the pancreas.
So after it's given its last tributary to the pancreas, that is where you would like it.
Yes, sir.
Okay.
Coming to low anterior resection, as opposed to the high anterior resection, the definition of the low anterior resection is when the anastomosis is done to the extraperitoneal rectum, but it is above the anorectal sling. It is indicated for mid and upper rectal tumors, which is about 6 to 14 centimeters from the anal verge. And the criteria is that we need to obtain a negative distal margin and the patient should have a good anorectal sphincter tone. So then the concept of ultra low anterior resection. So the differences between what is called as a low anterior resection and this is the ultra low anterior resection is here the level of resection between LAR and ULAR is below the peritoneal reflection. But the major difference lies wherein in low anterior resection, complete rectum is not removed. There's always a rectal cuff which is left behind. While in ultra low, the entire rectum is removed. Proctectomy is done and the transection is done where the mesorectum ends. The anastomosis in the LAR will be essentially a colorectal anastomosis because the rectal cuff is left behind. But in ultra low anterior resection, it will be at the level of the pelvic floor and essentially a coloanal anastomosis. LER is indicated for upper rectal and a few mid-rectal tumors, while ULAR is indicated for mid-rectal and a few distal rectal tumors, small distal rectal tumors where we can get away just above the, just at the level of the pelvic floor.
Nisha, I think you have to specify when you are saying anal canal and rectum, are you meaning surgical terms or anatomical terms? Because
so surgical terms. Surgical, sir.
Yeah. So the students have to understand that anatomical anal canal and surgical anal canal are two different things. The anatomical anal canal finishes at the dentate line. Anything above the dentate line anatomically is rectum. But surgically, as she said, that we take it as the anorectal ring, which is at the pelvic floor, and the two are not at the same level.
Same level, yes, sir.
Yeah, please carry on.
So what are the techniques that is being done to achieve a good length of the anastomosis is to obtain for a coloanal or a coloanal anastomosis or colorectal is to complete the splenic flexure mobilization and even the transverse colon mobilization from the lower border of the pancreas. So that's where we ligate our IMV and omentum can be detached from the distal transverse colon and the splenic flexure. High ligation of the IMA is at 1 centimeter from the aorta to spare the splanchnic nerves and IMB is at the lower border of the pancreas. That gives an extra length of 3 to 4 centimeters. Now coming to low rectal cancers, these are the tumors which are located within 5 centimeters from the anal verge. When we compare the low rectal tumors with those of the proximal rectal tumors, we see that the low rectal tumors are more biologically aggressive. Pathologically, they are poorly differentiated. They are associated with neurovascular invasion. They have higher incidence of mesorectal and lateral lymph node involvement. They have higher rate of local recurrence and a lower 5-year survival rate. That's why when it comes to the distal margin of low rectal cancers, the proximity of very low rectal cancer to the anal sphincter raises a specific problem as to when and until how can we preserve this anal continence without compromising the oncological safety? We need to balance out the margin versus the sphincter preservation when we are dealing with low rectal tumors. Studies have shown that the levator ani muscle, external anal sphincter, ischiorectal tissue, perianal skin are rarely involved by rectal tumors, even when poorly differentiated, and that the intraluminal and the mesorectal spread is rarely beyond 1 to 2 centimeter. That is when Moore and et al. Defined the DRM for the low rectal tumors reduced from 2 centimeter to 1 centimeter with or without the neoadjuvant chemoradiotherapy. And this was even validated by Norwegian Cancer Registry trial. And for the low rectal tumors, DRM below 1 centimeter is considered safe at the final pathological examination if the inked margin is free of tumor. It is said that the formaldehyde fixation reduces the DRM to up to 57% after 12 to 18 hours. That's why DRM should always be measured on a fresh specimen for surgical reporting. Like Sir said, again, 1 centimeter, less than 5 mm have all been described, but it always depends upon the biology of the tumor. If it is poorly differentiated, highly aggressive tumor, we need to have better distal margin. If not, it's better to always go in for an APR in these cases rather than having a sphincter conservation surgery. CRM for the very low rectal tumors follows the same lines as for the upper rectal tumors. That is to have at least a cutoff of less than 1 mm is considered to be as positive margin, and anything greater than 1 to 2 is threatened, and greater than 2 mm is considered to be as negative CRM. So for all the rectal cancer tumors, initially APR was limited to all the low rectal cancer tumors. The innovation of intersphincteric resection, which was defined by Sichel in the year 1994, came in for the subset of the low rectal cancer tumors, wherein they could go about by doing a sphincter preservation surgery as opposed to that of an APR. So in the year 1994, Sichel described that we can go in a plane between intersphincteric resection is to go in a plane between the internal anal sphincter and the external anal sphincter. There's a plane which is being maintained called as an intersphincteric plane, wherein we can go in this plane and resect the low rectal tumors for a very subset of the tumors, which is well differentiated, which I'll be talking about in the subsequent slides. And in these patients, they can preserve the external sphincter and the levator ani, thereby having a sphincter conserved surgery. Once that has been done, these patients, the bowel continuity is maintained by doing a coloanal anastomosis. So depending upon where the line of transection is it at the level of dentate line, or is it between the dentate line and the intersphincteric groove, which is essentially between the internal anal sphincter and the external anal sphincter, or is it somewhere midway? If the distal extent of resection is at the level of dentate line, it is called as partial intersphincteric resection. That is because a partial part of the internal anal sphincter is taken off. If the distal limit of transection is between the internal anal, between the dentate line and the intersphincteric groove, somewhere in the midway, it is called as a subtotal intersphincteric resection. And if our line of transection is at the intersphincteric groove, that is between the internal anal sphincter and the external anal sphincter, where completely we are taking out the internal anal sphincter, it is called as a total intersphincteric resection. The indications for the intersphincteric resection is well and moderately differentiated tumors, preferably T1 and T2, and in T3 only after a neoadjuvant chemoradiotherapy, wherein the tumor has been downstaged and it is away from the external anal sphincter. And contraindications to these remain poorly differentiated tumors, T4 fixed tumors with invasion into the external anal sphincter or a levator ani infiltration and untreatable distant metastasis, and those individuals with very poor anal function. It's better to do an APR in those individuals rather than to go in for an intersphincteric resection. So what was the Rulia's indication criteria was? Initially in 1993, Roulier said that the type 1 is the supraanal tumors, and type 2 are the subtaanal tumors, type 3 are the intraanal tumors, and type 4 are the transanal tumors, and intersphincteric resection was indicated only for type 2 and type 3 tumors. Well, the modified Roulier came in when the approach of transanal TME was introduced, And they divided the lower rectal tumors into type 1A, type 1B, type 2, type 3, and type 4, depending upon the extent of the tumors from the anorectal junction. So this is the dentate line. About a centimeter above the dentate line is the anorectal junction, which marks a surgical landmark between the rectum and the anal canal. So the type 1A tumors is when the distal margin of the tumor is 2 centimeter above, beyond 2 centimeter above the anorectal junction. So here we can get away by doing a low anterior resection. While in 1B is where the distal margin of the tumor is within 1 to 2 centimeter from the anorectal junction. And in these individuals, we will do what is called as a low anterior resection, and the anastomosis is at the anorectal junction. Now in type 2 is when the distal margin of the tumor is within 1 centimeter from the anorectal junction. And this is where we do in what is called as a partial or a subtotal intersphincteric resection. And type 3 is when the tumor is invading the internal anal sphincter. That's when we go in and do what is called as a total intersphincteric resection. And in type 4 is where we have the tumor invading both the internal anal sphincter as well as the external anal sphincter. And it is in these patients that we do what is called as an abdominoperineal resection, and the patient ends with a permanent colostomy. So to summarize, type 1A, low anterior resection, type 1B, ultra low anterior resection. It is in type 2 and type 3 where the concept of intersphincteric resection was introduced, both partial, subtotal, and total. And for type 4, it's the abdominoperineal resection. To understand the technique of intersphincteric resection, it's better to reconsider the anatomy here. So this is the anatomy that we see in the posterior aspect. So this is our rectum, this is our dentate line, and this is where we have our anal canal. As we go from anterior to posteriorly, we see that the circular muscle of the rectum continues as an internal anal sphincter, while the longitudinal, and which is being covered on its outer aspect by the longitudinal muscle of the rectum. The levator ani of the muscle continues as an external anal sphincter as we go lower down. This is the coccyx. So the longitudinal muscle gives off various laminar extensions, one to the levator ani, which is called as a hiatal ligament. And this, when we have to enter the intersphincteric plane, this is where we'll have to divide the hiatal ligament. That's when we'll be able to enter the plane between the longitudinal muscle and the levator ani and the external anal sphincter. So we need to divide this attachment, and then we will be able to go into this plane. And lower down, these give off what is called as a peritoneal ligaments, as well as it has been attached to the coccyx by the anococcygeal ligaments. While anterior anatomy in males and female differ, we see that the longitudinal muscle gives off the attachment called to the membranous part of the urethra, which is called as a recto-urethralis, and then continues lower down between the internal anal sphincter and the external anal sphincter. So when we have to go into the intersphincteric plane in the males, we will go in this plane, we will divide few fibers of the recto-urethralis muscle. This is where there is a very dangerous area because there's higher chances of injuring the membranous urethra here. And then we will enter lower down into the plane between the internal anal sphincter and the external anal sphincter. In the females, the similar here is in front between the vagina and the longitudinal muscle, we have what is called as a rectovaginal septum, which is a dense septum. So when we are talking about the intersphincteric plane here, it is between the vaginal layer as well as the longitudinal muscle. We go into the rectovaginal septum. We see a few intermingling fibers here, which is a dense area. We divide this area, and then that's when we'll be able to go lower down into the internal anal sphincter and the external anal sphincter plane. So the intersphincteric plane is not very clearly evident, especially in the anterior part, where in the males it is performed till the denon-villus fascia, which can be a dangerous area because again we'll be able to there's higher chances of injuring the membranous urethra. While in the females, it is at the dense area of few intermingling fibers. It is always advised to do the anterolateral dissection and before going into the anterior dissection.
Nisha, just a minute. Go to the previous slide. You said no. The next. You said that in males, this is a crucial dangerous area during dissection. Why?
So because, like we said, see here, the few fibers of this longitudinal muscle is giving off attachments to the membranous part of the urethra. So when we have to enter the intersphincteric plane, there we will have to divide these recto-urethralis fibers. And if we stay if we move in anteriorly, we'll be injuring the membranous part of the urethra. So that is why it's very crucial to stay close to the rectum along the longitudinal muscle, just outside the longitudinal muscle, divide the fibers and then enter the plane.
Besides this, there is something called as neurovascular bundle of Walsh, which is condensation of the inferior hypogastric plexus, which you get usually at the lower end of the denominal fascia.
Yes.
You have to be very careful of that.
Okay, sir.
Also, Nisha, in one of your slides, you mentioned intersphincteric abdominoperineal excision. Now, if you are doing an abdominoperineal excision with a permanent stoma, why do you need to preserve the sphincter? Intersphincteric resection is, the aim is to preserve the sphincter so that you can have, so intersphincteric resection will always go to one previous slide in one of your slides. And I think some text also mentioned that, which, yeah, total intersphincteric APE.
Oh, I'm sorry, sir. Sorry. This is my mistake. Sorry.
Yes.
Sir.
No, I think it is mentioned in some text also I have read, but.
No, this is a total intersphincteric resection, sir. I'm so sorry.
Yes.
There is no AP.
Yes. No, some texts I think do mention it. So you're not wrong, but there's no point. If you are going to have a permanent stoma, then you are not worried about saving the sphincter. Intersphincteric resection is, as you said, in well-differentiated early stage tumors where the external sphincter and levator ani are not involved. Now, Dr. Chetan, from
Yes,
this point of view, suppose you do an intersphincteric resection and then the histopathology report comes that no, the circumferential margin is positive. Then what are the options?
Basically, sir, I was just going to ask Nisha this question, is that the important prerequisite before taking up the patient for intersphincteric resection is good counseling of the patient and patient's relatives. Because after ISR, the quality of life of these patients is not very, very good. So, and this situation may arise more commonly than otherwise. So you need to counsel the patients that it could come as positive, and then you have the option of either doing a APR or you have to give the patient radiotherapy and keep the patient under surveillance. So these are the two options which are available to the patient. But given our circumstances, I think abdominoperineal resection is a good option for these patients.
Thank
Okay,
you.
Nisha, just can you come to the slide which Dr. Kapoor was questioning you? Yes. So this is actually the tumor invades the intersphincteric area and you are doing a total intersphincteric abdominoperineal excision of the tumor. You are preserving the external sphincter, but some people are, what Dr. Kapoor is actually mentioning is when the people are doing a resection and doing a colocutaneous anastomosis because you have a sphincter being preserved. So this is under trial that will an external sphincter give a same role once the colon is anastomosed to the skin rather than you have any mucosa over there. So there's a difference between the two. What you mentioned is correct, which is still in trials. So you are not wrong. You said sorry, but I think you are not wrong because from the place from you have copied is actually mentioning that.
So those patients will essentially have something like a perineal colostomy then. It will be like a
If you have a sphincter preserved, then it is not a colostomy. If you have excised the external sphincter, then it is a colostomy.
Okay, sir.
That is the study which is going on presently.
Okay, sir.
What quality of life is there?
That is under
just extending it for.
That is all under discussion. That is all under trials. So I don't say that it is an established mode of treatment, but yes, that is under presently being tried. Yes, you may go ahead with your normal.
Then one more slide. I just asked Nisha, what is those in that slide where she has said that that fascia is coming down and that it has an extension into where there is a danger of that urethra getting injured in days.
Yes, anterior.
What is RO, RU and UR?
Anterior part, Nisha. Yeah, this is recto-urethralis, and that is the membranous part of the urethra.
What is RS?
That is the membranous part of urethra. Now, so there's a PR is a prostate above, and then there's membranous part of urethra where you are dissecting in the LM and RU area. If you go towards
The RS stands for what? Huh? How can it be RS membranous urethra?
Nisha, what is RS? Dr. Chaube wants to know.
आदमी तो तुमने सही बोल दिया किसी और लैंग्वेज
Possibly where she must have copied it from some place where it is mentioned as RS, but what she means is actually that is the membranous part of the urethra, which is at high risk of getting injured.
by the position it is membranous
Yes.
urethra.
I think that is what we take care as soon as the prostate ends. We have to take care of that area because of the nerves as well as because of the membranous area of the urethra which can get injured. Yes, you may go ahead, Nisha.
So whether the sphincter conservation surgery or to go in for an upfront APR, the whole ideology changed when the concept of neoadjuvant CTRT was introduced, because they all went about by downstaging the tumor, reducing the tumor deposit, taking care of the micrometastasis. So this was initially helped in reducing the positive CRM and the local recurrence rate, especially in a locally advanced rectal tumors as per the NCCN guidelines. So the initial concerns of advising an ISR to the patients with infiltration to the extra-anal sphincter or the levator ani muscle, then subjecting these patients to the neoadjuvant chemoradiotherapy, thereby causing a tumor shrinkage. Whether once that is being done, whether to go in for a ISR or to go in for a APR depends upon how they have responded. If they have responded well, the tumor has downsized and the patient is able to understand the consequences of ISR, because these patients again have what is called as a very low anterior resection syndrome, which I'll be talking about in the subsequent slides. And like Sir said, if they can even have the possibility of having a positive CRM after the resection, wherein they will have to go in for a adjuvant radiotherapy at that point in time, or they can be converted into an APR at that point in time, was all been the concerns. So Piozzi et al. In 2021 said APR will be reserved for all the non-responders post neoadjuvant CTRT.
So Nisha, before you go to APR, let me interrupt you. Two basic questions.
Yes.
One is, what is your view with regards to lateral pelvic lymph node dissection while doing anterior resection?
Sir, again, Japanese surgeons, they says that they consider it as a loco-regional disease. Presence of lateral pelvic lymph nodes are considered as a loco-regional according to the Japanese, while the Westerns think it is probably the presence of metastasis. So to go ahead and do iliac lymph node, obturator lymph node dissection, that's highly morbid procedure. They're not been associated with a very high survival rates also. So lateral pelvic lymph node dissection, the recommendations and consensus are, if preoperatively on the MRI we are seeing the presence of lymph nodes there, or when it's a T4 tumor, we have given a neoadjuvant tumor or radiotherapy, and we are trying to do a curative resection there in a T4 disease. That's when the lateral lymph node dissection, LLND is indicated.
So basically, you very rightly mentioned that there is a great divide between the Japanese and the Europeans. The Japanese considered it as a very sacrosanct and they always would like to dissect it. However, the Europeans and the West, they say that once you give a neoadjuvant therapy, there is no need for doing a lateral lymph node dissection because of the increased morbidity associated with it. Now, second question is, when you divide the lateral ligaments, where do you exactly divide it?
You mean the hiatal ligaments, sir?
The lateral ligaments, while doing the lower rectal dissection, the lateral ligamentous attachment, where do you divide it?
So it's in the TME plane. We lie between the visceral layer of the pelvic peritoneum and the parietal layer of the pelvic peritoneum.
Will you go more laterally, or will you?
No, so we will not go laterally, because that's where our inferior hypogastric plexus lie, and there will be high chances of injuring them. So we stay very close to the mesorectal fascia.
So you have to remain medially.
Yes.
Third question is that why do they say that they keep on harping that you should be doing sharp dissection and not blunt dissection in the TME plane, especially lower down? Why? So
again, there are higher chances of blunt dissection. We have higher chances of entering into the, like I told you about the Kinogava's fascia, which is the fascia which lies just over the autonomic nervous plexus. So there can be chances of injuring these parasympathetic and sympathetic plexus, which is why it's always advised to go in, do a sharp dissection under direct vision.
So basically, apart from this, there are presence of small veins which have no valves. So they bleed profusely if you do a blunt dissection. Important thing, prior to taking up the patient for TME, they say it's a multidisciplinary approach. So what are the important prerequisites you would satisfy before taking up this patient for surgery?
First, whether we have had an MRI. On the MRI, we'll have to see the sphincters.
Is MRI a must?
Yes, sir. Now consensus are MRI is a must, sir.
So this is a very important point, especially for exam going students, that MRI is a must prior to taking up the patient, especially when you are going to do a low anterior or ultra low anterior resection. MRI is must to be done. Another important principle, you have mentioned all the principles of TME, is that a good traction, this surgery, entire surgery is based on good principle of good traction and counter traction. So it's very important that your assistant knows exactly how to give a counter traction and create that plane where you can go in very easy. Otherwise, I must comment that you described ISR very, very well, nicely, and very good with good diagrams. Go ahead.
Okay, sir. So coming to the abdominoperineal resection, as the name itself indicates, we have the abdominal dissection and the perineal dissection, where we'll be taking out the entire anorectal complex, both the sphincters, internal and external sphincters, en bloc with the rectum and distal colon. And these patients end up with permanent colostomy. The whole aim of doing an APR is to attain a loco-regional control of the disease through complete tumor resection and with negative circumferential margin. It is indicated in very low rectal tumors where we are unable to get a negative distal margin, and we see that the tumors are involving the external sphincter, or we also see their invasion into the levator complex, or those patients with a very poor baseline sphincter tone. So few people recommend, before doing an intersphincteric resection, it's always advisable to go ahead and do a anorectal manometry to look for the sphincter function. Few of the institutes do it, few of the surgeons still recommend that. So in those patients, there's no point saving the sphincter when it's not functioning well. So it's better to do an APR in these individuals rather than giving them an ISR and a sphincter conservation surgery when the sphincter is not functioning well. And APR is indicated for the recurrent tumors as a salvage therapy for the anal cancers, even benign condition where APR is indicated when there is a severe refractory anorectal Crohn's disease, which is compromising the sphincters.
It's not manometry. Both in your exam and for your clinical practice, a good digital rectal examination, which gives a very good crude assessment of the sphincter function, is a must before you plan any sphincter saving surgery. Also, when you are dealing with a patient with ulcerative colitis, before you decide to do a pouch anal anastomosis, you must have at least a good clinical assessment of the sphincter function, especially in elderly patients.
Okay, sir.
Yeah, please carry on.
Okay, sir. So APR, although was a last resort, it is again tailored surgical approach. The challenge lies at the level of levator ani to separate the mesorectum from the pelvic floor, because this is the area where we can have higher chances. So we need to get this area between the mesorectum and the levator ani. This is a chances where a lot of times it cones out and there can be chances of tumor perforation. So traditionally, the APR is divided into two types. One is a traditional or the standard APR. The other one is the ELAPE, which is called as extended or extra levator abdominoperineal resection, which is also known by the name cylindrical APR. So what we do in the APR is we follow the TME plane we take in the abdominal phase, and here we will have to cone out at the junction where at the level of the pelvic floor, we cone out the specimen between the between the outer longitudinal layer of the rectum and the levator ani, and then we, from the perineal phase, we take out both the we go into the plane beyond the external anal sphincter, and we take out both internal and the external anal sphincter and join the abdominal level at the level of the pelvic floor. So while in the extra levator approach or the cylindrical approach, what we do is we follow the same TME plane, but here we are not preserving the levator ani. We are taking off the levator ani along with the sphincter complex and the residual rectum in the distal colon. Here we divide the lateral attachment of the levator ani, and then we go lateral attachment of the levator ani. So what is called as a traditional APR or the standard APR is called as a waste, where we cone out the specimen. While in the ELAP, we don't cone out. We maintaining the cylindrical the end result after the resection is the cylindrical appearance of the specimen, because we are taking out the levator ani at the level of the lateral attachment.
So the best way to describe it in the exam would be that in the classical APR, the levator ani muscle is taken at its insertion into the rectum. Whereas in extended or extra levator APR, it is divided at its origin from the lateral pelvic wall.
Okay, sir. So just for completion purpose, the important steps of the APR remains patient with lithotomy position. We can place on urethral catheters to identify the ureter in the pelvic dissection. We can either do open midline or a laparoscopic procedure, rule out the extended metastasis, mobilize the sigmoid colon, follow the principles of TME. And for the perineal approach, we take in an elliptical incision, which is extending anteriorly to from the perineal body, posteriorly to the coccyx, and laterally from the ischiorectal tuberosity. And we go in, divide the anococcygeal raphe, reach higher up, and divide the ischio-coccygeus muscle using electrocautery or sharp dissection with the scissors, and reach anteriorly till the denominus fascia. So we'll be joining both from the abdominal side as well as from the perineal side. And once that is being done, we will be closing the levator ani muscle in layers. And this is how the perineal wound closure is going to be in a traditional APR.
Any comment
While,
about the position?
As opposed to the extra
Nisha,
levator.
Any comment about the position of the patient?
So, yes, sir. I'll be talking about here in the next slides.
Yeah.
Coming to the ELAPE, it is following the same principles of TME as well as the perineal approach, but just that we will be dividing the levators are detached laterally. So since we are dividing the levators, there's going to be a whole open cavity which will be left behind. So the ELAPE needs what is called as a myocutaneous flap. Either it can be an rectus abdominis flap or a gracilis myocutaneous flap, or even the biological mesh has been described to cover the defect. Large defect that is left behind in extra levator approach. So the indications for ELAPE has been the distal rectal tumors with circumferential invasion into the external sphincters involving the levators, and when the margin is threatened on the MRI. So the important differences between the APR and ELAPE being, initially when the APR was introduced by Miles, the patient used to be in the supine position, then went into the prone position. They had to change the position, but later on with the introduction of the leg and the stirrups, APR can be done in the supine position by keeping them in the lithotomy position, wherein it can either be done both by an abdominal surgeon as well as a perineal surgeon, or once we finish the abdominal phase, the same surgeon can start the perineal phase. While in ELAPE, essentially they say that we need to obtain the prone position for the reason that we need to divide the levator ani from its lateral attachments, which is better visualized, which is better done when the patient is in the prone position. Coming to the abdominal phase, the TME is up to the pelvic floor, both in the APR and the ELAPE. And the perineal phase, for the APR, we take off only the external sphincter, but for the ELAPE, we have to remove the external levator ani complex completely. So the differences in the oncological outcomes is, there are high chances of having a positive CRM on APR if the tumor is very close to the levator ani muscle. But since in ELAPE we are taking it off, the chances of getting a CRM positivity is very low. As I said before, the tumor perforation site, which is very crucial, is where the levator, the junction between the levator ani muscle and the longitudinal margin of the rectum. That's why there are higher chances of tumor perforation. So when we are doing an APR, when we are trying to cone out, we can have tumor perforation, but that is not there in the ELAPE. But as opposed to the extensive surgery that we do in the ELAPE, the wound complications are quite higher. They need a tissue reconstruction or a mesh placement, which is not much in the APR and which is not seen in the APR.
I remember Dr. Ramesh Ardhanari saying that as a routine, he prefers the prone position, especially when he is dealing with a large tumor, because he feels the exposure is better. Dr. Chetan, what is your approach?
So our experience is very limited with regards to prone approach. We are very happy doing in lithotomy position, sir.
Okay.
So what about you all? What approach do you all practice?
So we are doing it in a lithotomy position.
Yeah.
But definitely once you have it in a prone position, the surgery becomes very technically easy and it is very comfortable. But the problem is once you have done an abdominal part, then you have to change the position. And when you are doing the perineal position, you can't do abdominal position. That is the biggest disadvantage of having it in prone position. But if you see the traditionally, whatever surgery you have to do between coccyx and the anal verge, it is always better approach to the perineal approach. So in the prone position. So now if you see doing both by both the sides, one surgeon standing on the head end and one surgeon standing in the perineum, it can't be done in a prone position. That is the biggest disadvantage.
Yeah, please carry on.
You have to change the position. Prone के लिए तो that is the biggest.
Nisha, you may carry on. We have only few minutes left, Nisha.
Yes, sir. So coming just for completion purposes, open versus laparoscopy and robotic, they say that the laparoscopy is technically challenging, needs steep learning curve, but improved early post-operative outcomes and it's oncologically safe. Well, robotics has better ergonomics, more magnified view, so we'll be able to go into the extended abdominal phase as opposed to the perineal phase. Color trial, classic trial, Koreans have described that the laparoscopy is not, the outcomes with the laparoscopy versus the open is comparable as opposed to the a la carte trial and the ASOG trial, which has shown that the laparoscopy is inferior to the open. This is just for the completion purposes. As when we compare the robotic versus the laparoscopy as seen in the ROLAR and the COLAR trials, they've said that the robotic have lesser conversion rates and longer operative time, but however, the perioperative outcomes, functional outcomes are all statistically similar. Now, coming to the complications, we know that intraop,
Nisha, hello,
Yes, sir.
Nisha.
Yes, sir.
This is your last slide.
No, sir, I have more slides.
So just because time is short, let me ask you some questions, typical exam questions. In an APR, where will you stop your abdominal dissection lower down? At what point?
At the level of pelvic floor.
Where exactly? At what point? Both anteriorly and posteriorly, at what point you will stop?
So posteriorly, after we divide the after we divide the this thing, just at the level of the hiatal ligament.
You stop it before the proximal end of the coccyx, and anteriorly you stop 1 to 2 centimeter just above the tumor. You have to stop it anteriorly.
Okay.
Now, what is the philosophy? So, though you have already answered this, how did the ELAPE procedure evolve? What was the reason for going to ELAPE, switching over from APR to ELAPE?
So the whole idea was that after the APR also in a very aggressive tumors, which is locally advanced, and during the procedure, tumor perforations were very high. So
why tumor perforations are very high in APR?
So because we cone out the specimen at that junction of the coccyx, where our levator ana and the outer longitudinal muscle is there.
What is the anatomical reason?
Reduced space. There's no much of.
There is thinning out of the mesorectum. In fact, there is no mesorectum, and that area is denuded of fibrofatty tissue.
Yes, sir.
So that is why in your abdominal dissection, you stop there and then come from below. And that is the whole concept why you have to take a cylindrical rather than get a cylindrical specimen rather than avoid waste.
Yes, sir. Okay.
Right?
Yes.
So these are the two important. What is the important prerequisite before taking up the patient for surgery? For APR.
So adequate counseling, sir, because these patients end up with permanent colostomies.
So extrapolation of that, which students usually forget, is sighting of stoma.
Okay.
You need to pre-decide where you are going to bring out the stoma, counsel the patient accordingly. What about bowel preparation? Do you give bowel preparation for these patients?
Sir, evidence has said that
just think logically. Will you give bowel preparation for this patient? You are doing an APR for a low rectal tumor. Will you give a bowel preparation to this patient?
Yes, sir. We want to avoid the contamination.
You want to avoid the contamination. The patient is obstructed or partially obstructed, no?
If they are obstruction, partial obstruction, we don't give.
So basically, you avoid as far as possible bowel preparation. What they say is you give the patient liquids 2 to 3 days prior.
Okay.
Liquid diet.
Okay, sir.
Right?
I think, Nisha, you have to understand what Dr. Chetan is emphasizing, that any patient who is having a partial bowel obstruction, a complete bowel obstruction, if you tend to give preparation of the bowel in the form of a peg-leg or something, it will like to have a more distended bowel and more likely liquid content of the stool, which will spill and which is likely to have more contamination. For the Indian patients who have more of solid stools, it is found that the spillage of that solid content of the stool is less harmful. So people have started going towards non-prepared bowl even for the advanced rectal surgeries nowadays. Though there is some recent, in last 3 years, there has been some change in trend now again from some people have started trying the bowel preparation again. So I think that is what Dr. Chetan has been emphasizing on that.
Now,
Second
Nisha,
thing,
okay, sir. Go ahead.
what Dr. Chetan has said is stoma. I think you have to understand that there is a difference between a general surgeon doing a APR and a GI surgeon doing a APR is a GI surgeon will always have a prepared stoma site. I always say if somebody is not having a prepared bowel stoma site prior to the surgery being marked as per the patient's requirement for his lifetime, then it is like any other routine surgeon which has been done for last so many years. So that is a basic conceptual difference that you have to understand.
Okay, sir. I have a doubt, sir. Do we put in a mesh in these permanent colostomies because colostomies have higher chances of parastomal hernia? Is there any indication to put in a prophylactic mesh?
No.
No.
Nisha, do you in your practice routinely send the donut for histopathology?
Yes, sir. We send, sir. Both proximal and distal.
Very good. So now if the donut comes as positive, how will you manage?
That depends upon so once the
So
surgeon
you have done a ultra low AR and the donut comes as positive.
Okay.
Convert to
adjuvant chemoradiotherapy.
You will give adjuvant. This patient has been given neoadjuvant radiotherapy. Donut comes as positive. You will want to give an adjuvant.
So then I'll give option to the patient, sir. Either go in for an APR in these patients or keep them under surveillance to give an adjuvant radiotherapy in these patients, depending upon the choice of the patient.
So basically multifactorial things you will take into consideration is one is the patient's age, then what is the associated morbidity, and you counsel the patient and this. Okay. If the patient is elderly, lots of morbidity, it's safer to convert into APR.
Yes, sir.
Nobody will question you.
Okay.
So at the end, I think it was an excellent presentation by Nisha. I think what we were expecting, it was many times better than that, Nisha. That's what I would like to conclude. And a very good moderation by Dr. Chetan. And I think we can have more sessions. All the residents should understand that if your absence of your active discussion makes this a less lively discussion, because what Dr. Chetan is asking, what Dr. Kapoor is asking, and what we are asking is actually at the level of a consultant level. We want more questions at the level of residents. That will be more informative for all the residents who are your colleagues. So more interactive interaction with the residents is required. Second thing is that you have to understand that almost all of these presentations will be loaded on YouTube subsequently. So these are very important presentations which you are making for the society in the coming years as well. So thanks. I think I'll like to pass on to Dr. Kapoor to conclude.
Yeah, that's important. That I also feel little disheartened and disappointed because this session was started mainly for the students, and I find that students' participation, except for some students who regularly ask questions, and I think I can name Govind definitely. He is always there to ask questions. But I want more students to ask questions. And thank you, Dr. Chetan, once again for your time.
Thanks a lot.
We would be very happy to have you again in one of the sessions.
I was very happy. And in fact, sir, our students would also like to join in and present.
Yeah, they can send a mail, a message to Dr.
I will ask them.
Anand. Yes.
I will ask them to send.
Yes, they can definitely join. Thank you so much.
Sir.
Thank you, Nisha, for a very good presentation.
Nisha, excellent presentation.
Thank you, sir.
Bye.
Thank you, everyone.
Thanks.